Good afternoon, everybody. Welcome to SADS Live, episode 124. Great to get to be with you today, or good evening for those in Europe. Good morning, I think, for those down under. And I never know if my brother, Chris Samsarian, is watching, but if you are watching, good morning, brother. Great to see you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and our complementary Winland Smith Rice Sudden Death Genomics Laboratory. But like all times, all Fridays, I come to you as the privilege of serving as the president of the board of the SADS Foundation. We are the Sudden Arrhythmia Death Syndrome Foundation. Our CEO is Alice Laura, and her staff have done an amazing job serving the needs of our SADS families affected with genetic heart conditions like long QT syndrome, like CPVT, Brugada syndrome, arrhythmogenic cardiomyopathy, and so forth. We are probably the largest, not probably, we are the largest, and perhaps really the only nonprofit advocacy organization that's truly devoted to families with these kind of sudden death predisposing heart conditions. But we don't fear it. We don't fear the possibility of sudden death. We respect it, but our expectation is for all of our families, once diagnosed, to live and thrive despite their condition. And we see and hear amazing stories. Of course, unfortunately, we still hear awful tragedies of a death that could have been avoided, warning signs that weren't recognized or acted upon, family history where that his story wasn't realized or respected as part of their story. So we have work to do, and that is one of the missions of the SADS Foundation is awareness. Another pillar of our organization is support, to be there for when that family, newly diagnosed or diagnosed decades ago, calls and needs handheld over the phone or over the Zoom, somebody to walk that journey together. So for those of you who've been part of us on the SADS Live for now 3.5 years, I think. I think it was February of 2020, and unbelievable. 3.5 years together. It's great to be with you. I am very fortunate to serve on the board of the SADS Foundation, have done so for a long time now, became the SADS Foundation's second president after its founder, the late Dr. Michael Vincent. He led it from 1992 to 2006. And since 2006, I have partnered with our CEO, Alice Laura. We have a wonderful board, and I'm really excited. I've been looking forward to this for 4 days. Why 4 days? Because about 4 days ago, we elected to have join the SADS Foundation 4 new board members. They're not new to SADS, but they're new to our board. They've been volunteers. They have participated. And of the 4 board members, one new one, you all know, he's actually my mentee, my trainee, Dr. Andrew Landstrom, genetic cardiologist at Duke University. We've had him on SADS Live. He's done webinars for us. So I'm not interviewing him today. Who I am interviewing are 3 wonderful women who have joined the SADS Foundation, not as disease specialists or professionals, but as personals. In other words, those who have personal investment in these SADS condition because these SADS conditions are theirs. And so we have joining our board a wonderful woman who represents the community of arrhythmogenic cardiomyopathy, and you're going to hear Christy's story, and then a family representing Brugada syndrome, and you'll hear her story, and then we'll bring on Suzanne as her story is that of catecholaminergic polymorphic ventricular tachycardia, CPVT. So we chose to go in alphabetical order, A, B, C. So Aaron is going to bring up A for arrhythmogenic cardiomyopathy, and our newest board member, Miss Christy Johnson. Christy, welcome to SADS Live.
Thank you so much for having me, doctor. I'm so happy to be here.
It's great to have you. And for those of you who've watched, and 2 weeks ago, somebody commented on the sidebar that did a ghost open the door just as the program started. And that ghost did it again. That's my lovely Brittany Spaniel, Bella, who just seems to have to join me for the program. So again, 2 weeks in a row, everybody, that was why the door opened up and you didn't see anything. Christy, welcome to SADS Foundation. As you know, you're one of our 4 newest board members, and we're delighted to have you join us. But as I mentioned in the intro, you and the 3 of you women, you're joining us because your connection to us isn't professional. It's not because you're a physician. It is because it's very real and very personal, because it's yours.
Yes.
Tell us your family story.
Absolutely. So my family story actually goes back, for me, only 3 years, but for my history, a lot longer. And I thought that was actually really interesting. So I'm the proban in my family. And actually, just really briefly, the start of my journey started in April of 2020 during COVID. So, everyone picture COVID. I was making lunch at my kitchen counter when I went into what I learned after going to the hospital was very fast ventricular tachycardia. So I had to be shocked 3 times in the hospital to get me back into normal rhythm. And even at that point, they were saying, this woman has some genetic thing. And it was really interesting because I didn't know what. I was in the hospital for a week, in the ICU most of that week. They did install an ICD immediately. But looking at my history, which wasn't put together until I was in the hospital, my dad passed away in his sleep at age 52. He was a very active, athletic man who had just taken early retirement, and passed away, sudden, clear blue sky. My aunt, his sister, died of heart failure at age 60. They thought she had a virus as a child. So now we know that my family, my dad, my aunt, unfortunately a cousin, my daughter, all are positive for the desmoplakin pathogenic variant. And so that is what we're diagnosed with as a subset of both ARVC and dilated cardiomyopathy. So unfortunately, it's one of those lovely genes that hit both things.
So your story is like so many families, isn't it? Where you may be the proband and it may be a new diagnosis of as of 3 years, but there's been years and years worth of a story that the puzzle pieces just didn't get put together or connected.
Exactly. And so that was actually really, really challenging. And I know that for a lot of families, that's one of the challenges when they start to put together, all of the pieces and realize that this is a family story and doesn't just impact you. It's impacted past generations and it's impacted future generations. And I'm thrilled with genetic testing and the way that we've come through, because again, I think we can save so many lives. I think we would have saved my dad's life, right, if we would have had that there. And then also, I know we'll get to this at some point, but there's just so many new treatments and therapies and gene therapies on the horizon that are so exciting. Yeah. So I think there's so much hope for this family story.
That's wonderful. And as you know, Christy, your family's condition generally under the header of ACM or arrhythmogenic cardiomyopathy, for which there's many, many different flavors. And you shared with us your flavor of desmoplakin mediated cardiomyopathy. You're probably the newest member to the SADS Foundation community. We were founded under long QT syndrome by the late Michael Vincent, added the other channelopathies very early on in its history of Brugada syndrome and CPVT. But I would say probably within the last 3 to 5 years, we reached out for families with ARVC or ACM to see, did they really have a home? We have various academic centers of excellence, the Hopkins Center for one, that's one of the leading ones in the United States, ours at Mayo Clinic and so forth. But did we really have a home for the families? And it's been wonderful to add ACM under the umbrella of a SADS condition for those families to feel like they have a place. How have we done so far? So since you're the newest member of the club,
yes.
And speaking for the families, do you think the SADS Foundation has put out the open arms well enough? Do the families who have ARVC find us as their proper home, and are we meeting their needs?
So I think we have done amazing things as SADS, right? So SADS has done amazing things for ARVC, arrhythmogenic cardiomyopathy, especially from what I've seen in the last year. So I think the efforts are ramping up. When I first called, I talked to Genevieve, and who does not love to talk to Genevieve because she's amazing. I had a neighbor with long QT who said, you really have to call and talk to SADS because they deal with arrhythmogenic issues, and they probably will talk to you. But I still think that was early on. And I do think SADS is still making a lot of progress in their support and their outreach to ARVC, arrhythmogenic cardiomyopathy patients. I'd like to see more of that. However, I think the monumental effort of the patient-focused drug development meeting that was just done as a SADS-led effort was the most amazing thing that I've seen for ARVC advocacy and for support ever. I was so impressed, and I've read a lot of research. Yeah. I've done a lot of things, and it was so impressive and so wonderful to see. And any of the ARVC, arrhythmogenic cardiomyopathy people out there, please go check it out. There's a lot of links that SADS has. There's both a patient advocacy sort of meeting as well as a scientific meeting where doctors comment on it. And it's really just an amazing event altogether. So take the time, please go look at it. So I'm sorry, that's a long answer to I am thrilled with what we're doing for ARVC and ACM. And I think there's just so many more efforts as well that are going to be wonderful in the future with SADS.
So you have a double whammy going on, don't you, Christy, as mom with it, who owns a defibrillator. You mentioned your daughter, and you can share as much or as little as you want about her and her diagnosis.
Yes.
But you're not only a patient, but you're a mother of a patient. That's a lot.
Yes. Yes, it is. It's a lot, and it's been really challenging. She found out that she was positive for the condition the day that we dropped her off at college her freshman year. It was a Sunday, and her doctor called to say, you have the disease, and I think we need to get a defibrillator in immediately. So later, she was able to wait, but she also has scarring and did so at 17 years old. She was a competitive swimmer as a young child, and I'm not saying that's why, but she had quite a bit of fibrous tissue already at 17. She has had one arrhythmogenic event and been in the hospital, and she now does have an ICD, which I'm very, very grateful for. And she is not letting it stop her. She got into an early acceptance medical school program. She's going to go to medical school and hopefully help us in our SADS journey at some point, and just continue living her best life. So I'm very proud of her, but it has definitely been a journey.
Yeah, that's wonderful. Your family's condition is very recent and real to our program. I've met a wonderful young woman, college student, who also has desmoplakin cardiomyopathy and came for a second opinion. And long story short, not pleased at all with the MRI, said we need to treatment intensify and get a defibrillator in pronto. Yep. And then, of course, we have that wonderful world called the private insurance companies, where for whatever reason they think they're a smarter doctor than I am, and they refuse the defibrillator. And so we are doing battle right now. For now, I'm giving them the opportunity to do the right thing, so I won't name that insurance company, but I have the tweet ready to reveal, and the gloves will come off, because I just cannot stand it when the insurance company thinks that they know how to care for our patients better than we or the family does. And so I put in the note for this peer-to-peer review that is going to happen on Monday, that if she dies suddenly between now and then, the death is on their hands. And it's just maddening to see the issues and the challenges we have still with, a lot of our families need intense treatment.
Absolutely. And Dr. Ackerman, I had 0 symptoms. Well, that's not true. I had some pulsating in my neck. 9 months earlier, I'd had a full heart screening. They're like, oh, you're fine, go away. 9 months before my major event, right? So PVCs, a few here and there, there was not the signs, right? I think that's the hard thing for people to get their heads wrapped around. You don't always have signs for years when it comes to some of these issues.
Yeah.
I think that's such an important thing to have ICDs, and I love the work that SADS does as well with ICDs and the support there.
Right. And I know Lori on the sidebar, hi Lori, is sharing that her daughter's insurance refused the defibrillator. They have long QT. And I think that allows a very interesting opportunity to talk about that even though we're the right home for the various families, the role of the ICD is very different in the various SADS conditions. So a lot more ACM, especially desmoplakin, ALVC, where it's the left ventricle that's involved, their threshold to heading towards the ICD, or I would say the distance, is a much shorter distance. It's a much more irritable substrate for which we have no confident treatment strategies to prevent dangerous arrhythmias. On the other hand, the SADS community knows that for our long QT community, I spent a lot of time and energy scolding heart rhythm specialists for throwing in defibrillators too quickly, too unnecessarily, too often when they have long QT. And we're going to meet a mom with CPVT. And that's another genetic heart condition where we actually try as hard as we possibly can to not install a defibrillator. And so I think that's one of our challenges too, for the SADS Foundation is our families have different conditions, and there's a lot of things that we share in common, and we can enrich each other by that common experience in terms of stresses that occur. But the treatments aren't necessarily identical, and the when we need to invoke treatments X, Y, and Z are at different points in time for the different SADS conditions, and that's just something for our SADS audience and members to be aware of, is that when we speak of how amazing it's been and thankful for you and your daughter to be protected with an ICD, we almost never need to say that for long QT families because most of them don't need an ICD.
Right. And I say, if you don't need it, that's great not to have it, because there's some issues, of course, having ICDs.
Yeah, absolutely. Well, Christy, I'm going to have Aaron bring us up B in the alphabet. I think you're going to stay on.
Yes.
So we'll keep you on. And if questions are ready to come on through, I'm keeping an eye on them like Lori's. And if we have time to share the questions, we will do those. But our second board member who joined us as of 4 days ago is a wonderful woman where their family story is B, Brugada syndrome. And we don't talk a lot about Brugada syndrome in the SADS Foundation, but again, we are here for families with Brugada syndrome. So let's meet our newest board member. And I think it is, yes, Sandy. Sandy, welcome to SADS Live.
Thank you so much, Dr. Ackerman.
And it's great to have you as a fellow board member. You and Christy and your colleague Suzanne are our newest ones, and we're just excited to have you, because having those where the diagnosis is real because it's theirs always helps us, remind us, or help us stay anchored onto our true north and make sure we're meeting the needs of the families. Speaking of those needs, Sandy, give us a little insight, if you will, about your story and your family story with Brugada syndrome and how then you've come to discover the SADS Foundation.
Sure, absolutely. So my story started around 2009, although similar to Christy, it started well before that. But that's when I became aware of Brugada syndrome. My father had been passing out his whole life. Nobody really knew why. It was kind of always diagnosed as just a vasovagal episode, and there was no concern with it. But now knowing the warning signs, like you had mentioned earlier, had we known those warning signs and had we connected the fact that if he was sick and he had a fever, he would typically pass out. Had we known then what we know now, things might be different. But in 2009, he had another episode where he passed out, went to the ER, and at that point was diagnosed with Brugada syndrome. Soon thereafter, he had an EP study done to assess the risk. And 9 days later, unfortunately, he passed away.
Oh,
So we, at the time, I had really wanted to go to a specialist, being one of 4 children, and there's 8 grandchildren in the family. So I went to NYU, the Heart Rhythm Center, which I'm very thankful is only about 2 hours away from my home. And at that point, I had some genetic testing, which came back negative. I also had the test done, a drug infusion with procainamide, which came back negative. And my siblings also had that same test, all came back negative. But I continued to go to NYU on an annual basis with my son, who is now 19, and just continue to be, have our regular checkups and just kind of stay connected. And then Dr. Trone from NYU had reached out in 2016 and said there was a clinical trial to redo the test, this time with flecainide. So I did that, and it was positive at that point. So I was diagnosed in 2016. About a year later, I went to a family day at NYU, and that's where I was introduced to the SADS Foundation. And I am so, so thankful that I was, because just having that community has just been incredible for me. It's I think it was a very lonely journey along the way without knowing anyone else with this condition. And even medical professionals, when you say you have this and they ask you how to spell it, it's a little disconcerting. So having this community has been just tremendous. So again, my son is 19, and we continue to watch him. At this point, he has not been diagnosed, but I feel like he's in very good hands with NYU. And at this point, I do not have an ICD, but I do have a link monitor just to gauge the risk level that I'm at right now. Assuming that I stay away from any triggers, my risk level should be pretty low. That's where I'm at, and that's how I came to the SADS Foundation.
well, it's great to have you, Sandy. And it's interesting when we think of Brugada syndrome and we talk about genetic heart conditions, and yet for many Brugada families, there's a frustration, isn't there? Because most of Brugada syndrome in 2023 is still gene test negative,
Right.
whereas our long QT families, if you truly have long QT syndrome, the genetic test will come back positive about 90% of the time. We're going to meet Suzanne, and I don't know if she is positive CPVT or not, but if that diagnosis is correct, the genetic test comes back positive at least 2/3 of the time. For Christy, for ACM, if they truly have ARVC or ALVC, the genetic test comes back positive about half the time. But for your family's conditions, if Brugada syndrome, if it's the correct diagnosis, despite being the correct diagnosis, the genetic test only comes back positive about 20% of the time, 25% maybe, which is
Right.
telling us that a lot of Brugada syndrome may not even be genetic. If it is genetic, it's probably more complicated genetics than just one gene from one parent that gets passed on in a 50-50 rate. And so I think that's always, I find it as the physician, disappointing and frustrating that I don't have clarity of guidance,
Sure.
like for your family to be able to say, yep, we found yours, Sandy, and your son does not have it. He's
Right.
dismissed.
Right.
We don't quite have that luxury in the Brugada family community. And so I think that's a stress for Brugada families all of its own, is because nobody ever really gets clearly dismissed.
Right.
It's sort of, things look good so far. Let's look again. And
Right.
uh, does that impact you and your son, or not that much?
I would say you described the anxiety that we have felt for many years.
Yeah.
Yes. Yes. Until, between the time that my dad died and when I was diagnosed, there was a lot of anxiety because, like you said, everything was coming back negative, but it's still hanging over your head that you could have it. I had some symptoms that would lean to saying I did have it, but it wasn't caught yet, if you will.
Mhm.
So I almost think, in a way, being officially diagnosed, I felt like I had more control over it at that point, because it was definitive. There was an answer. So we essentially take universal precautions with my son and say, let's just say he has it and he avoids any triggers. We treat him as if he does. So that way, God forbid he took some medication or something that might be on the list, we want to know that we're treating him as if he has it, because he does have a chance of having it.
Right, right. Well, in terms of SADS Foundation and Brugada syndrome, what kind of pulse do you have with the Brugada syndrome community? I'm not honestly, I'm not as aware of sort of what are some of the offshoot Brugada chat rooms or support groups. Do those exist like they do for kind of the long QT families? And if not, what can we do at SADS to have Brugada families feel like they have a better home? I think we've been a good home for Brugada families, but I think we at SADS, and hopefully with you as the voice of Brugada syndrome, or representing that constituency, if you will, we can make it an even better home where their needs really are being met.
Yeah, absolutely. As as part of the research committee, I know there's a lot of research happening surrounding Brugada, which is really exciting. So I know that's been a focus, and I've been to some SADS webinars and talks about that. And I think, just having that connection with other Brugada families is so important, and that's helped me tremendously. So I really look forward to kind of being a voice on behalf of other Brugada families, so that we can continue to raise awareness and support each other.
Yeah. Well, you're at a great place. I have a lot of good friends at NYU, and we at SADS are at a great place having you and Christy now part of the SADS board. So thanks for your willingness to join us in that, and really looking forward to getting to know you and see what we can do to make the SADS Foundation, even better going forward.
Great. Thank you so much.
That's great. And Kayla, I see your question, and we'll see if there's time to address that. And that brings us to C, because it's good timing with that question, to our third board member, not a professional, but a personal. Again, a board member where SADS is real to them because it's theirs. And the theirs condition in Suzanne's case is C, catecholaminergic polymorphic ventricular tachycardia, or CPVT. Now, CPVT is not as common as long QT syndrome, probably more common than Brugada. If long QT is about 1 in 2,000 people, CPVT is probably on the order of 1 in 5,000 to 1 in 10,000 individuals. So let's bring on one of those 1 in 5,000 kind of human beings with Suzanne. So Suzanne, welcome to SADS Live.
Thank you. Thank you. I'm glad to be here.
And rounding out the trio of the three amazing women to join our board as of a few days ago, this is Suzanne Bennett. And so we heard of Christy, and her story is arrhythmogenic cardiomyopathy. And she knows the gene is a gene that builds the protein desmoplakin. Then we heard Sandy's story, and unfortunately we lost her dad, possibly from Brugada syndrome. And we don't have the luxury of knowing the genetic name for Sandy's Brugada syndrome. All we know is that she reacted to a drug called flecainide at this time, and her family's being closely monitored. Suzanne's story is CPVT. So Suzanne, tell us a little bit about how that diagnosis was discovered in your family.
Well, we were officially diagnosed in 2020, just like I think it was Christy, right before COVID happened. Luckily, ours was in January. But my son, Cowin, he's the one affected. And he started having symptoms in 3 years prior to that, even though we didn't know that they were symptoms of CPVT. He actually passed out while he was playing basketball, running as he was dribbling. He just fell and passed out. And at the time, we chalked it up to him being nervous or not feeling well. So we didn't really think a lot of it at that time. About a year went by, and he experienced another episode that we didn't witness. He was actually getting into the shower, and we heard him scream. And my husband went in there, and he was laying on the floor, kind of like he had a seizure, we thought. We didn't know what had happened to him. He didn't know. Now we know that he actually passed out. And he recovered fairly quickly. But at that time, I knew it was time for us to take him to the doctor and figure out what was going on. So I made an appointment with his with his pediatrician. And she, looked him over. She felt his heart. She was listening to his heart. And he was nervous, and she told me that he was experiencing some PVCs that she didn't think that he should be. At his age, she didn't know why he would have that. So she wanted us to go see a cardiologist. And at the time, I thought that was kind of crazy. I was like, there's no way something's wrong with his heart. But, we went to the cardiologist and had an echo and had an EKG, ECG, and everything was great. And they didn't talk about doing a stress test or anything at the time. They wanted him to come back in a year just to check out a little mitral valve reflux that he said was normal, but it should resolve. He just wanted to see him. So I said, great. So Cam went on his way, and he was involved in athletics, and he tried out for the basketball team. And by God's grace, nothing happened to him that entire year, his 8th grade year. And so we went back to the cardiologist for the follow-up, and everything again looked great, except he had a junctional rhythm on his EKG that the cardiologist wanted to look at further and wanted him to have a Holter done. And at that point, I was getting a little nervous. I have a health background, so I knew that maybe not be good. We had the Holter done, and then I got a phone call saying they wanted him to come in for a stress test. And I knew that was definitely not good. And we had the stress test done, and he was a trooper. He exercised for about 10 minutes.
Wow.
I know. And, he had a lot of movement, I guess, on the EKG. The cardiologist was not in there when he had the EKG. When he had the stress test done. And the tech kept saying, I think it's just artifact. And she kept asking him, how do you feel? You feel okay? And he was like, yeah, I feel fine. He was just going along and then it was done. Well, we got home. And as soon as I got home, there was a phone call from an electrophysiologist's office telling me they wanted to see my son as soon as possible. And I hadn't even heard back from the cardiologist yet. And I knew that meant there was something not good. And she told me briefly what they thought it might be. Of course, I started Googling it and was terrified. But we got in really quickly with the electrophysiologist, and he was very frank with me and said, this is what I think he has. I remember he wrote it down on the back of a paper, the long, catecholaminergic polymorphic ventricular tachycardia. And he told me, he said, you're very lucky nothing happened to him during that stress test. He said, because if I would have seen a fraction of what was on that stress test, I would have stopped the test immediately. So that's when our life changed, and my very athletic, sporty son had to scale it back. But he took it like a trooper, and now we're just he's medicated. He's good with this medication. And it's funny that you talk about the flecainide, because we love the flecainide because we have to be on it, right? Or he does. And so actually, I also want to say that we all were tested. I have a 14-year-old now. his brother, and we were all negative. His brother had a beautiful stress test, and my husband and I have both been genetically tested, and we don't have the gene. Ken is the only one with the gene. He is my de novo lucky one that has it. My sporty one. His brother could care less about sports, and he's the one that's fine. It always works out that way, I guess.
Yeah. It's so interesting, isn't it? Just in the three of you women, we have, just as we said at the outset, desmoplakin. We know Christy's families, and we can find the excess marks the spot and dismiss those who don't, keep those who do. And then for the Brugada syndrome, there's no cause identified for Sandy's family. It's gene negative, as it often is. We had mentioned for yours that without knowing it, that if your diagnosis in your son was correct, that test should come back positive 2/3 of the time, and it indeed did. And as we often see in CPVT, at least often as in more than in long QT and the others, is there's a higher rate of new in you mutations, meaning where your son is the first one and it is a de novo, like you said. So healthy sperm, healthy egg, Shazam after the fact, after the creation was made. And then it's his and his only for now. Of course, now that it's in your son's genetic code as new in him, it's now 50% chance for every child that he creates in the future. And again, in your story, they use flecainide to bring out the diagnosis for Sandy. But in CPVT, flecainide has been one wonderful new additions in our treatment strategy, where it's standard treatment more often than not now to have our CPVT patients on combination therapy with beta blocker and flecainide. And flecainide has been an amazing drug for our CPVT patients to get their rhythms under great control. And where our strategy now for families with CPVT is, as we say, to cure the stress test, to make your son's stress test look like he could go full throttle all the way. And his stress test would look just like his brothers and moms and dads, meaning we've gotten rid of all of the CPVT triggered ectopy. And so it's great to have that story of your families represented on the board, because it is such a good, accurate reflection of CPVT. I think the other thing, which our mission together with you will be, we have got to shorten the time frame from first symptom to correct diagnosis in CPVT families. We are the worst in the medical community to respect this condition, to take somebody who has strange spells, exertional spells, for which years can go by and still nobody's done a stress test on the individual. And so if you and I together with SADS can solve that one, that would be a great day, because it just drives me crazy to take care of families where there have been tragedies out of disrespect for that first spell. And years have gone by. Last week, we had a patient family. They had been to 4 different heart rhythm specialists over the span of 4 years, and still no stress test. And so we have, I don't know the why behind that, but we have got to make it standard care that anybody who does a faint, does a seizure during exercise, that they must have a treadmill stress test.
Right. He also had a really low heart rate always, and I never thought about that before until looking back. His heart rate was always like in the high 50s and low 60s, which I know is bradycardia, which I know can be a symptom of CPVT. Not everybody has it, but it's just funny now that his pediatrician, nobody ever mentioned that to me, that he should have a higher heart rate.
Yeah, that's a tricky one, right? Because low heart rate is so, he sounds like he was a healthy athlete, and healthy athletes have slow heart rates. So that's always a tricky one, isn't it? Well, it's going to be so wonderful, Suzanne, to have you and your new mates, Sandy and Christy, to really help us. And like I said at the beginning, I think we are clear with our mission at the SADS Foundation, but there's nothing like having families where this is their thing to hold us true to what our mission is and to always keep us focused. And the focus must be the families. The families with SADS conditions have to be the epicenter of the SADS Foundation universe. And we need you to make sure that we never stray from that, because the families are everything. They're my why in my career, and the families that I've personally have been privileged and blessed to get to be called their physician. They're my true north. And I think for the SADS Foundation, we always need to make sure that that's the case for us as an organization. And I think we do that well. And I see Genevieve already is reaching out to the sidebar to Julie, who during our time together said, hey, can we talk about short QT syndrome, which we're there for SADS families where that's their name too. It's just that for short QT syndrome, long QT can be 1 in 2,000 people. Suzanne's son has about a 1 in 5,000, 1 in 10,000 condition. Sandy and her dad has about a 1 in 10,000 condition. And then we come to short QT, which is probably on the order of 1 in 50, 1 in 100,000 people. So we don't give it as much voice as we could or should. And Julie, I see that Genevieve has already connected you. And so we will walk hand in hand with you and your family. There was also another great question that we won't have time, Kayla, but we're going to park this one of yours. It's a really good one and we'll pick it up. And speaking of picking it up, Erin, thanks for bringing all 3 women on. Suzanne, thanks for joining the board. Great to have you, and all 3 of you, thank you for choosing to join us in this really important way. And for all of you, that's a wrap. We're at the top of the hour. SADS 125 is in 3 weeks. Do not miss this. Tell your friends about this. I am interviewing a couple of colleagues who have great experience to talk about clinical trials. What should you look for in a clinical trial? How do you know if you want to participate, should participate, could participate? What are the questions to ask? How do you get connected to that clinical trial? How do you make sure that your local physician is aware? You don't need their blessing necessarily. This is your right, but having them part of the team is mission critical for you and your family. And there's a lot of clinical trials starting, patients being enrolled as we speak for a CPVT trial that Suzanne's son has. Gene therapy trials getting set in motion as we speak, not for Sandy's condition yet of desmoplakin, but kind of a cousin, that of plakophilin or PKP2. So we are in a brave new world where there are more clinical trials for SADS conditions that are started or starting in these last 3 years than in my first 20 years on staff. An exciting time, but it brings new questions, new issues, new things to be aware of. And we're going to try to help equip you with that. So join us in 3 weeks, September 8th, same time. And I think you will like it a lot. Until then, have a wonderful rest of August. And it looks like it'll have to be a wonderful Labor Day because we get together after that. I leave next week to do a retirement celebration for a dear friend and a wonderful friend of the SADS Foundation. He's like a brother to me, mentor, Dr. Arthur Wilde. And we're going to be celebrating his official retirement from Academic Medical Center in Amsterdam. He's not leaving. He's just moving on to better, getting to retire from all of the bureaucracy headaches and just getting to do what he loves to do, which is to take care of families with SADS conditions. So we'll be celebrating Arthur Wilde next week. And then the week after that, I will be in Hong Kong joining the SADS Foundation Hong Kong chapter and meeting with them and hearing their stories of those SADS families. And I can't wait. So shout out to SADS Hong Kong, and I can't wait to be with you in a couple weeks. For now, blessings and peace to all of you. Have a wonderful, wonderful couple weeks.